Hello and welcome to the forum. I'm Kate Kelland and I'm a global health and science correspondent at Reuters. This is a live Q&A about India's COVID crisis. And the title of our discussion today is Variants, Vaccines and Surges. Joining me is K. Vish Viswanath, Director of the Harvard Chan India Research Center, and Louise Ivers, Executive Director of the Massachusetts General Hospital Center for Global Health. You can post questions for us on Facebook at forum HSPH, or you can email them to theforum@hsph.harvard.edu. The Q&A is jointly presented by the Forum at Harvard's T.H. Chan School of Public Health and by Reuters. India is currently experiencing a catastrophic surge in COVID cases, with nearly 400,000 new infections recorded every day. Today, India recorded more than 4,000 deaths for the second straight day, and the number of new infections is overwhelming hospitals. We've seen TV pictures of families weeping over their dead loved ones, and bodies are being washed up in the Ganges, the vast river. It's a very dramatic and tragic situation, and it's gotten so much worse since the winter. It could, of course, also be a warning for the rest of the world of what might lie ahead. So, Vish, I wonder, please, if we could start with you. Could you give us your assessment, please, of what's been happening in India?
Sure. So let me first thank you, Kate, and thank the organizers at Harvard Chan and Reuters for this very timely Q&A session. So there are three factors that really are causing this crisis in India. So we know the data. Close to 400,000 people are infected every day, almost between 350 and 400,000. 4,000 people are dying every day. These are official statistics. Undocumented could be much higher. So that we know, I think, and anybody who's exposed to media, news media, will know that. But there are three factors that I think we need to understand and contextualize for the current crisis. So one is, I think, a challenge of leadership, in a crisis situation. So what I mean by that, and I have a different take on this, and not about a single political party or political personality or groups of personalities and parties. Obviously, I think we'll have to assess how the issue of governance under this crisis, and we'll have to take a very close look at what happened. But I'm talking about in terms of coordination and leadership at a national and state levels, where you're developing these guidelines to whether it's in the clinical level or in the public health level, developing policies, developing enforcement issues in a very unified way, and providing the appropriate information at a national level and at the state level. That kind of a leadership is really necessary, and it looks like it is just not there. The second issue is that of not taking public health seriously. So I agree that if you look at the data, and if you look at the incessant pictures of funeral pyres, or as you said, bodies floating down Ganges, I think it is heart-wrenching or gut-wrenching. At the same time, even if you agree that tens of millions have been infected with COVID-19, because there are those that have been undiagnosed, still there is a group of billion people who have not been infected with COVID-19. And I think, a lot of attention is being paid to the distress at the clinical level, and rightly so, but the attention to public health strategies, to getting people to, or preventing that disease from occurring in the first place, infection to occur in the first place, we are not talking a lot about it. I think, that's a public health issue. And then the last one, and I'll be happy to elaborate on any of them, is a crisis of communications and mobilization. Number one, I think one crisis is, in communication, is that there is no, everybody, in the absence, in a great deal of uncertainty like this, people are trying to make sense. And when there is no clear communications and transparent communications, people try to make up stuff and rely on other people to make sense of it. That's a huge, huge issue. And there is a lot of misinformation, again, that is floating through social media. And the lack of instrumental information. You see people asking for beds, vaccinations, oxygen generators, because there is no central coordinated way to disseminate that information. And therefore, as a result of which, you are not able to mobilize the population to act in a unified way to comply with public health mitigation measures, which is very, very critical for this crisis to be minimized. I think these are some of the challenges.
Thank you. There's a lot to talk about there. On a very broad population level. Louise, I wonder whether you could give me your sense of what's happening within the slightly narrower within the health systems in India and how they are coping or not.
Yeah, I mean, I agree with everything that Vish has said. And it's just, I mean, it's so devastating. It's such a the human toll is tremendous. And as a medical doctor myself, my heart is just really breaking, not just for the patients and their families, but also for the healthcare providers, because they're working in these very, very challenging circumstances. And I think, the problems are fundamentally familiar. We had in the United States, we had our own surges of COVID-19, but we had better medical infrastructure to begin with, although we had our challenges. I think one of the especially saddening things at the moment is to see that here we are a year later, and many of the lessons that we learned about the things that we know work, whether that is in the hospital setting or in the home setting for those who are mildly ill, or from the public health prevention perspective, are just not really being cohesively put in place. And it's a very, very challenging situation.
And can you give us a sense of how the Indian healthcare system would normally work under kind of normal circumstances, and where are its weak spots in this, where are the particular challenges that are posed by the COVID pandemic?
Well, first, I think for those who may be watching who are not familiar with India, it's important to remember that it's a very large country with many states and a very diverse population and a diversity of access to healthcare in the first place. So typically at the federal level, there's a small percentage of the GDP actually spent on public health care. Although in theory, everyone has access to healthcare at a government hospital, a lot of times there has been kind of substantial lack of investment in those government hospitals over time. And this is a familiar situation that we see in many places. And by the way, I will add, the United States has not really heavily invested in public health in many circumstances too. But you see also about 2/3 of the population of India living in rural place, but rural healthcare is much less accessible, much less robust than might be available in the cities. And a lot of people, a vast majority of people, are usually getting their healthcare by paying out of pocket. So even though that government service is there and available, and many really hardworking folks there, the number of doctors and nurses in that system is really not as much as it would be. Now, there are other countries, even in the region and other parts of the world, that are much less well positioned actually to respond to COVID-19. So there is capacity in the Indian healthcare system, but it's not exactly dispersed around the country to all the places that need it. And obviously at the moment, we're having just this massive crisis of need. And I think not only are people unable to get the care they need for COVID-19, but also presumably, though we haven't seen a lot of data on this yet, other healthcare is now being crowded out of the system because so much of the system is needed to respond to COVID-19.
Yeah, which of course we've also seen in other parts of the world. I wonder whether we could talk a little bit, Vish, to you about two aspects. One is the data. You talked a little bit about it. How accurate do you think the numbers that we're seeing coming out of India are? And are we lacking data? Are there gaps in this data that we could use to inform or could be used to inform a more useful response?
Right. So it's a mixed picture, I think. So what we have is we have some epidemiological data on infections, number of infections, recovery rate, number of deaths, and hospitalization. There are about 1.1 million doctors in India, allopathy trained doctors, so we have some idea on the number of hospitals, number of beds, etc. I think the issue is always an underestimation in terms of testing and infections. To that extent, people are struggling, given that testing is not widely available, I think. So that's one. But despite that, there are some people who have been able to develop some great models. Modelers, both in the US and in India, have been able to use it, I think. The real challenge there is data utilization, and that's not helping us, because it doesn't tell you what kind of data you need in real time and how you can make a decision on it. And it's not very clear how those data are being utilized and models are being utilized, already being generated by a number of groups, research groups, in India and here. The second issue where we lack absolutely no reliable data on the population side, on the behavioral side. We don't know how many people are wearing masks. We don't know how many people are staying at home. We don't know how many people are doing hand washing. And we don't know why they are doing or not doing it. And these are data that are underestimated, because they are not as dramatic as a patient gasping for breath outside a hospital or a funeral pyre. But the fact of the matter is these data are extremely critical to develop the appropriate public health strategies and communications. And those data are really not available. So.
And as you say, there are these billion people who haven't yet, to our knowledge, been infected, and they're the sort of invisible ones, but it's incredibly important if we can find ways to protect those people from infection. I have to ask about the variant as well, and so there was a variant which I think we don't call the Indian variant; it's called B1617. It has just been labelled a variant of concern by the World Health Organization. How much do we know about the variant? How much data are we getting? And could it be that variant that's driving this surge? Is it a symptom of the surge or a driver of the surge?
Maybe I can take a comment on that first. I think certainly we're seeing this variant really emerge as very predominant in the outbreak and the surge in India right now. I think it seems indeed that it's very likely this is a more transmissible variant. It seems as though it might be as much as 2 times more transmissible as other variants. But I think it's important to think about all outbreaks as being both, microbiological and social. Like the microbe, in this case, the virus, has to land into a context in which it can thrive. And so what we've had in many different places over the last year, and now in India at the moment, is this perfect storm of both a variant that seems to be more transmissible and also an environment in which it has been allowed to thrive, or it has found the opportunity to thrive. And for a variety of factors, including, mass gatherings, whether they were religious or political, or just the fact that for many poorer countries or middle-income countries, they are having to endure these, other approaches, these public health approaches of social distancing or masking or lockdowns. They're having to endure them at a pace that vaccination can't really keep up to give them an endpoint to. So for many reasons, whether they are just kind of pandemic exhaustion or whether they are economic, people are having to get back to their livelihoods or have to get back to work. So I think, yes, the variant does seem important. And a lot of the conversation in the West, I think, has been focused on, oh, well, should we worry about this variant for ourselves? Whereas, it may be important for us. Scientists are scrambling at the moment to try to understand how the vaccines that we're using will be protective against it. It seems so far that they will. There's still science happening there. But I think it's important to just think about the virus, of course, in the context that it finds itself.
So the variant is important, but there are other factors that are contributing to this surge. So Vish, can you talk about? I mean, obviously, one of those factors could well be the government's response, and whether it's whether the leadership is there, whether there's a coordinated strategy. Can you talk a little bit about what you're seeing there?
Right. So I think I want to emphasize or re-emphasize, I think, Louise's point here. I think the variant is of concern, and rightly WHO has pointed that out. There is actually a very distinguished group of people in India, virologists, microbiologists, who are working on it as a part of a consortium. They're actually doing the sequencing, identifying the genetic signatures. They are actually trying to do small testing in animals to see the transmissibility and the effects of the mutants on antibodies, etc. So actually, there is some very interesting work going on in India, even as we speak. And this consortium is actually convened by the government, and some really interesting work is going on. And the reason I'm emphasizing that is there's a tremendous amount of expertise that is already available and at work in India on these very same issues we are talking about. What the context in which this is being spread is where the problem lies, which I think Louise so rightly pointed out. I think it is the super spreading events. We are talking about religious festivals and elections. But even at a micro level, people having weddings. Until a few weeks ago, I was getting wedding invitations, right? So it is these kinds of things where the lack of fear, vulnerability, and compliance, and directed strategies to mitigate that is where I think that it has become a tremendous source of the surge. I'm not discounting the virus itself, or the mutation itself.
So, I mean, we have some questions sent in from members of the public who are watching us, and some the questions are, many of them around the variant and what kind of factors, but also about this issue of lessons learned. I mean, this is not the first wave of COVID-19 in India. Did Indian authorities fail to learn lessons the first time round? What could they have done differently?
I think this is clearly the case. And so today it's India, which is going through the crisis. But if you go across the world, it is quite stunning that we don't seem to have learned our lessons. We don't have time for me to go into the history of it, but the playbook has been very clear for public health emergencies. It's been very clear, but for whatever reason, we have failed to follow it in the US and now in other countries, and now we are seeing that in India. If you go back and look at what a number of Indian researchers have been saying, a number of researchers in the US have been saying, clearly they have been warning that it is not over yet. Even when the surge started, when the infectious rate started going down in last September, they were warning us about it. But for whatever reason, right, I think, people have opened up, people have become complacent about this. The governments have become complacent and declared victories. And people, there was a tremendous pressure. This is a point that Louise began alluding to, right? There is this framing, which is very unfortunate, lives versus livelihood. And so when you frame an issue that way, you already lose it, right? In the interest of livelihood, lives lose the place. And that's what has happened because the economy tanked. It has been a significant adverse impact on the poor, the marginalized, and therefore governments were shy of taking any coercive corrective measures. As a result of which, I think here we are, and people have been seeing this trend from March. But had we been prepared, and I think partly also we use this term first wave, second wave, third wave as if it's disappearing. It's not going anywhere. It hasn't gone anywhere. It's right there. It's just looking for ideal conditions, optimal conditions. And so, yes, it's a short answer is I think we collectively failed to say this and take appropriate measures and get ready for this, And my big fear is it will happen in the US unless we get the vaccines done completely in other countries, and India will face the same issue all over again.
And is that one of your concerns as well, Louise? Whether it seems it seems such a shame that India has, we have learned in other parts of the world some ways of getting to grips with this pandemic. Why have those lessons not been passed on? Is this a communication problem, or is there are people just not listening, or what's?
I think there's a couple of problems. Our ultimate way forward globally is vaccination. I mean, our vaccines are looking robust. The way for us as a global community is really widespread vaccination, and we can come to talk a little bit about some of the challenges there. In the meantime, we're asking people to really endure to endure quite challenging circumstances, whatever they might be, whatever socioeconomic level you're in. The challenges of staying home or distancing are not to be, messed with. It's hard. And so I think from a leadership perspective, it's absolutely about trying to communicate with the population. And that can be quite hard if you have historically not really been trustworthy. So I think some of the challenges we see, and it's not specific to India, but around the world, is that if the public health system has not really served the people well, then the people are not always necessarily totally trusting, and it's understandable. So the challenge has been in this crisis to try to have kind of cohesive key messages, to not be too hasty in saying we've victory. I mean, we don't have victory. We haven't had victory really anywhere. And that we have to stay the course together globally to be able to get to the point where we have large percentages of our population around the world vaccinated. That is really the way forward. So I think communication is maybe even just too simple of a word about it, because it's a very profound kind of message. And I think, I learn every day. I read the Indian scientists, papers. The challenge, as Vish said, is not the lack of science or knowledge within India. All of us have had to, have our science filtered up to our political leaders, and to try to hope that our political leaders would do the right thing based on the science that we have.
So I want to talk a little bit about vaccines, and then if we could come back to, I think there's a discussion to be had about misinformation as well, probably. But we have some questions coming in from members of the public. And we have a question here from Jim. Instead of waiving patents, wouldn't a better approach be to global vaccine equity, be to have taxpayer subsidies go directly to the pharma companies to pay them to produce their vaccines for free distribution? This would be around the world, but specifically in India as well. Of course, we've got one of the biggest vaccine manufacturers on the planet there.
Yeah, I mean, I think the kind of things we are talking about, the regulatory steps that are needed to be taken, whether it is the TRIPS waivers or whether it is subsidizing pharma industry. We already did that, actually. We've subsidized pharma industry to develop these vaccines in the first place, except for one or two pharma companies. Most of them have received money. So it's a taxpayer money they've received. And it's a scientific miracle, right? It's not miracle. Miracle is a bad word, but it is an amazing scientific development that we do have vaccines. But none of these will solve the problem in the short term. I think, so we have to scale up that capacity to build, and that's not going to happen overnight. I think, so to us, I think the big problem right now is how do we scale up, number one. And number two, WHO actually has some data on this. Most of the vaccines have been already bought up by industrialized countries, right? So they don't need them. I think they bought more doses than they need for their population. I think there has to be pressure on these industrialized countries, our countries, to loosen those restrictions and start distributing them. You don't need these vaccines in those numbers. That's where the real pressure is, even as we try to scale up. And that is being already done.
But I wonder whether in this very acute phase of the surge in cases in India and the urgency of the situation, does it make sense to put the energy into vaccination now, or should the energies of the doctors and the healthcare systems be going into finding oxygen, getting dexamethasone, finding and as you've said, protecting the people who haven't yet been infected with social distancing, mask wearing, so on? Where should the energy be going? Is vaccination right now the answer?
I would say, look, we need to have a whole of government approach. There needs to be a whole of government approach to any pandemic. And that is true for any country. And when sometimes actually we kind of falsely pit one aspect of the pandemic approach against the other, when really what we just need is more energies. This is an absolutely devastating pandemic, economically, health-wise, lives-wise. Like, we should be all in here. I think we can't relent on the drive to get vaccines to people. This is, at the moment, our best shot at preventing, loss of life. I think the doctors should still keep, and the nurses and all the healthcare community health workers should keep doing what they're doing. And we need to think of creative ways. I mean, I like the idea that Jim mentioned of ways to approach it. The public dollars billions of public dollars have gone into developing these vaccines, but let's think of a number of approaches. The TRIPS waiver is one piece. I think nobody really working on this would say that the intellectual property is the only piece. There are other parts, like there are trade secrets, there are raw materials, there is actual physical manufacturing capacity. We need all of those things, but we as a human population have done really pretty dramatic things before. When we are all in and we have a sense of global solidarity, we can do big things. So I think often people will say to me, oh, Louise, like, it's complicated, it's complicated, as though we are incapable of embracing complexity and doing it together. So I think yes to all of the ideas on how to get this moving, but not really overly wanting to pitch one thing against the other. We need comprehensive approaches to the crisis.
Yeah, absolutely. And so I have one more question that I wanted to ask about treatments, Louise. What kinds of treatments do patients in India have access to, and are they getting them in the volume that they need?
Well, again, I mean, India is a place of many contrasts and a lot of heterogeneity. And, you can have the best possible medical care, in the world in one place, and little access to the most basic treatment for a diarrheal disease in another place. So I want to be conscious of not trying to talk about the place as a monolith. What I think is a challenge is that we have actually only a handful of treatments that we really know help to save lives in this disease. I mean, it's fairly basic, oxygen, triaging, some amount of steroids. Others are available. They are, some are still being studied. Some have been studied. Ivermectin and hydroxychloroquine are the most studied drugs, I think, ever. I recently saw an article looking at the number of studies on them. And yet what we're seeing in India is a lot of diversity of guidelines. So the Ministry of Health have certain guidelines that are recommending some treatments, but at the state level, different things are being recommended. And then there's wide public discourse about different treatments. So then patients are coming and saying, or family members are saying, I want to get treatment A or I want to get treatment B. So providers are feeling really much under pressure to respond in such a devastating situation. And, in our own experience here in Boston last March and April, we did, I think we'll all admit, we had a kind of, do something approach. So we didn't want to see our patients die in front of us. So we thought we would do a lot. Over time, we've really streamlined back and we're much more evidence driven now in what we do. So I think patients and people in India, I've heard stories of them buying things over the counter, of searching to 10 different hospitals trying to get a treatment that actually might not even really be that helpful. So I think it's very complicated kind of medical milieu to be trying to be a doctor or a nurse in, as well as being a patient in.
And I wonder whether that, Vish, I wanted to talk a little bit about the misinformation, and in some ways that's connected with this sort of idea of trying kind of treatments that are unproven. We should be clear that there are very few. Dexamethasone, oxygen have been found in trials to be useful. ivermectin not so, and is not recommended by the World Health Organization. But I wonder whether how this kind of information is being passed around, and is that part of the problem here?
Right. So a lot of this information is an effort on the part of the people to make sense of what is happening, and a feeling that they are not getting the complete picture. So on the one hand, there is tremendous pressure, and I cannot imagine being a doctor or a nurse or a frontline health worker today in India. There's a tremendous pressure on them to prescribe certain types of medication, and even threats in that case, right? And all of that is coming from, not from Twitter or other places, but places like WhatsApp, right? So someone reads something, whether it's a news release somewhere or some story somewhere, and starts spreading this information on different kinds of treatment. Two types. One is these kinds of English medication, ivermectin or hydroxychloroquine, whatever it is, are folk remedies. And then in turn, because there is a lack of this unified information or messaging, which I've been talking about, people are now trying to do their own selective interpretations of this. They're not clinically trained, but they know enough to say they have to go and demand it. And when it is not available, they have to use their connections or money to go out and buy this medication, even hoard it, or go from pillar to post to buy this medication. I think that is the challenge we have right now, because a lot of these conversations are happening in media outside clinical control of any kind.
So I want to go to another question from the audience now, and this one is on how we can really help India. It's a question from Nava, and it says, what can or should we do to really help a country address this crisis? Not in academic terms. I mean, obviously, we're all sitting here talking about it, but is there something real we can do? And the question says, in a real and timely, needle-moving sense, what is there? What action can be taken?
So I can go ahead and answer this one. The first thing is trying to talk to people in India, the institutions in India, the groups in India. What is it they need, right? It is so because, and this is, I keep saying this, right? Because we are seeing these incessant pictures of funeral pyres and oxygen, people gasping for breath for oxygen, etc. We all think of this in terms of clinic and somehow get anxious to do something, which is a good thing. The bad thing is, do we know that this is what they need? What do they need at this point? So one thing I would urge people is to talk to people in India, talk to groups in India, talk to physicians in India and nurses in India who are on the front lines, the NGOs in India. That's first thing I would do. Second, there are a large number of groups, very well-meaning groups in the United States, collecting donations, collecting equipment and sending it to India. I don't want to name them for obvious reasons on each individual one, but there are, on the internet, there are a number of these very reliable organizations. Obviously, you want to make sure these are reliable, but there are a number of very registered, reliable organizations which have the capacity, because it's just not easy to send foreign exchange into India. It's just not easy to send oxygen generators to India, right? So you have to have a system and infrastructure in place for distribution there. So there are a number of organizations, you can go to them, donate money to buy this equipment so that they can transfer it appropriately. And then work with groups in India, because it's just not enough to send it there. They have to have the capacity. As I said, there are just about 1 million doctors in India, for 1 billion people, or more than 1 billion people. They're just overworked. So, and very few specialists. And now they're enlisting specialists, radiologists, anesthetists, whoever is available to come and help here. So what do they need in terms of help to take care of issues? I think patients. So I would first start talking to people there. Then I would rely on some organizations here to figure out what exactly is needed, rather than jump the gun to start sending material.
Yeah.
So
sorry. I was just going to ask about, is that okay?
No, please do go ahead. I'd be interested to hear. I mean, a couple of questions on this subject are coming in about whether, again, what can really be done, and also whether donating to various NGOs and things does it mean that things like donations of oxygen will actually get to the right people, and how do you help that get to the right people?
This is really important. So I think there's the humanitarian crisis, and how is the best way for anyone who's not there to actually contribute to the crisis at hand. And often that is trying to get cash there, and vetting, trying to find local organizations, trying to find Indian-led organizations. Here at Mass General, we have partnered with an organization called Mission Oxygen. They are there in India, they're working, they can use cash, we vetted them. We know, for example, you have to do your research to find where to donate. But I also wanted to mention that I think for those of us who are not in India and want to be allies in this work, it is very important and can be needle moving for us to engage our own leaders, whether that's in the United States or in Europe or in other rich countries where we have hoarded the global vaccine supply and where we are not really stepping forward in leadership to say that we have a global movement on solidarity here. I think our leaders can exert some influence, they can put some funding behind a global scale up of the response. So even though it might seem a little detached from the crisis of the moment, this crisis is going to continue in India. The surge is not going to stop suddenly. So and by the way, other countries in the region are seeing similar exponential increase in their cases, even though the populations are obviously smaller, but we're seeing a big crisis emerge in Nepal. I do expect this to be occurring in other countries as well. So I think as you think about how can you help, of course, is the humanitarian need of now, but also don't dismiss how impactful you can be on leaders of the countries that need to get on board here with a global plan for the pandemic.
And what we're talking about there really is vaccinations, right? Donating doses, getting doses, keeping the production of doses within India. Is that one of the key problems?
We talk a lot about vaccinations because that's an end viewpoint to how we can get there. But we also have like a major gap in diagnostics. Many countries, and probably in India right now as well, mostly people who are symptomatic are getting tested. In many countries, the testing capacity has had to be directed to that because of need. So if you can't even detect cases, how can you contain them? So I think what I'm talking about is, for example, in the United States, calling on the Biden administration, not just to be focused on what's happening in the US, but and yes, it's nice to donate ventilators and international development aid, but to really step up on the global stage and say, how can we together create a global plan engaged with the WHO that really is meaningful and put resources behind it as well. And I think if we in the US and in Europe stand up to our leaders and say, we want an engagement here, this matters to us, it's very easy for us, like once we've survived our own crisis, to look over there and say, oh, that's something else, like that is someone else's problem. But this really needs to be all of our problem. And I think we can engage in that, and that is impactful.
Yeah, just to add to that, I think there are three ways, right? So one is on the policy side that Louise is talking about, which is absolutely important. And I think mobilizing our own leadership in Congress and at the federal level is very critical. I think they can do a number of things, not just one thing, right? It's making sure the raw materials, the supply of vaccine development, vaccine production, as well as medication. All these things, I think, can be aggressively taken by the governments. But also the technical help, I think, it's, we have done that before. When there is an Ebola crisis, we have sent personnel there not to help some of these countries. There is already a tremendous expertise, but it is this, they're overworked, right? Is providing that kind of a technical support would be very valuable here, I think, and then of course, you can do the other things which are absolutely essential in a disaster like this. But technical help, policy changes here, and working very closely globally. This is a global problem. It's today's India's problem, but it's a global problem. And having that global mindset is absolutely critical, I think, in this. So.
Yes, indeed. So we have another question that's come in. It's quite a specific question on the variants and on rapid testing, which we were just discussing. There's a question from Vardhan. Are there variant-specific considerations for rapid test deployment and for the sample type? So, for example, I've heard that the Indian variant evades detection in nasal samples. Now, I don't know whether either of you can address that issue, but is the testing that we have sufficient to be able to detect the variants that are currently spreading?
Yeah, at this time, there's so many different kinds of rapid tests, by the way, so it's actually hard to give a specific answer to that because that would require everyone to be tested against the variant. But generally speaking, at the moment, we are still able to detect this by the standard test of PCR. Rapid tests, it really would depend on the specific type and how good they are. A lot of the rapid tests are actually really best used for people who have symptoms. And in many ways, if you have symptoms, at the moment in India, if you have symptoms, you should probably take that as an indication to isolate and to quarantine, etc. So it's a little hard to answer that question specifically, Kate. That's not the biggest concern at the moment, that we're unable to test it. It might be that in time we find some of the tests are less good at it, but it's not the biggest concern on our minds, I would say.
Okay. And I wonder whether we could then talk a little bit more about what the potential risk is to the region. Is it, could we take this opportunity to help other countries, neighboring countries in that region, learn from what's going on, so that this doesn't inevitably, this surge doesn't inevitably happen in other countries in the coming months?
Yeah, I think this should be a wake-up call for everyone, every country, every community that does not have access to a high coverage of vaccination, which is everywhere, needs to be aware of this and to be concerned by this, and especially the countries that have even less health system capacity. I am very, very concerned about what might happen in other countries. The Africa CDC director a couple of weeks ago said this was a wake-up call for Africa and really called on leaders around the continent to, not be hasty in relaxing their own restrictions. So I'm very, very concerned for other countries. We see in Nepal, we see in other places how this is causing exponential growth. So yes, I think we have to stay on alert, and I hope it's other leaders are seeing this as an opportunity to double down on preparedness, to reinforce the messages, to get prepared, because I definitely have concerns.
Yeah, it's already happening. In fact, as you know, the 617 variant has been found in 40 other nations. You're already seeing an uptick in cases where there have not been cases for a while now in South Asia, in Southeast Asia, and other parts. So again, I really, really don't want all of us to be here on another call a month from now, 2 months from 6 months from now, discussing the same issues, because that's what is likely to happen unless, we learn and take action right away.
And so maybe getting vaccines to those countries, more vaccines to those countries that have not yet seen this is a priority. I have another question on that. From Marla, again, it's on vaccines. Should we be prioritizing vaccinating children and teenagers in the US? I think it's about to start in Britain as well. There's a discussion when they seem less impacted by the virus, and when there are adults, vulnerable adults in other parts of the world who have received no vaccines.
Talk about losing sleep. I can't sleep at night thinking about this dichotomy. And, it's a tragedy. I mean, the US has, I'm delighted for adolescents and teenagers, and this will be impactful in local transmission in the US and in Europe. And yet we have healthcare workers still on the front lines who don't have vaccine. You know, rich countries are 25 times faster now at getting their people vaccinated than poorer countries. Less than 1% of, global vaccine has gone to the African continent. You know, it's a moral catastrophe. We have to do something about it, whether it's specifically, stopping adolescent vaccinations and pivoting. I mean, there needs to be a bigger plan. We have to look at beyond our own borders. Like it makes absolutely no sense to be thinking that we could isolate ourselves in some country that has some, political border to it and be somehow not engaged in a global movement around trying to resolve the pandemic. So I appreciate the question. It's a big challenge.
Right. I think that's what I meant by global mindset, Kate. I think if we start framing that way, one against the other, from a public communication perspective, we are already losing the game, right? Because then you can easily say parents, if either Louise or I say one should do the other, you can easily see parents getting angry. You're actually mobilizing a group of people who are against it, right? Even though we are vaccinating children because we want to make sure they're healthy, we have a healthy summers, but frontline workers, high-risk people are not getting it. But I think that's the reason it's pushing that global approach is very critical, so that we don't use this kind of oppositional frames. Because anytime we use this oppositional framing from a communication perspective, I think you're already mobilizing people on one side of the frame or the other, and then that, the battle is lost.
I'll just add that generally speaking, I think a fundamental theme in global health equity, and if we just pause on COVID for a minute, but we think about diabetes and access to insulin, humans have created a false notion of scarcity of medical supplies. Like vaccine scarcity is a falsehood. It is created socially, and therefore we can socially deconstruct it. And, this is a mindset shift that is, I'm sure I'm going to have people telling me that I don't understand capitalism or innovation or whatever, but, this is something that we can actually change. And I really appreciate Vish's point about communication being key here and not pitting the wrong people, because we end up arguing, pitting one solution against the other when we need all the solutions.
Yeah. We need a global approach. So I just wonder whether we've only got literally 2 minutes left. Can I just ask you both just to give me your kind of biggest concern and your biggest hope for India right now? Vish, you go first.
I think my biggest concern is a lot of attention being paid to the clinical side, which is absolutely needed, hospitals, the clinical systems, the healthcare system, but not sufficient attention being paid to the public health mitigation strategies and public health communication strategies. If we don't do that, I think, we still have 1 billion people who are yet to be infected, so to speak, and we really need to prevent that. And that's my big concern. Again, it's not either or. It is just a question of bandwidth and attention. My biggest hope is, I think what this has done, more than anything else, is it has mobilized people in ways that you could not imagine. I think, entire globe is paying attention to this. Pretty much a lot of stakeholders are paying attention to it, and they're putting pressures on their own government to take actions. And my hope is that this kind of a global attention could be capitalized to take this kind of a global approach, equity approach, and really, start solving the problem in India, but also start paying attention to a number of these other countries. This is an opportunity that should not be lost.
Thank you. And Louise?
Yeah, I think my biggest concern is just really the suffering. I mean, the suffering of people, their families, the healthcare workers, the tragedy, the loss of life. I mean, it's really heartbreaking and devastating, and in many ways preventable. And I would say my biggest hope is that we actually know a lot of what to do. We know what to do, and we have to embrace the idea that we could, at least to some extent, deliver.
Thank you. Thank you so much. It's been a fascinating discussion, and thank you both, Vish and Louise, for fielding everyone's questions. The Q&A was presented jointly by the Forum at Harvard T.H. Chan School of Public Health and by Reuters. Thank you so much for watching.
Thank you for having us.